Hello, Dr. Prabh Nayak. Welcome to the MedEdge Podcast. Briefly, I understood that you are a cardiac pediatric intensive care specialist. Can you explain?
Sure. So the specialty that I work in is called Pediatric Cardiac Intensive Care.
Okay.
It's primarily for children who are born with congenital heart disease.
Okay.
So it's a very specialist part of children's intensive care in general itself is a very specialized field.
Okay.
And we have subspecialties that have developed over the last few decades, especially over the last 10 years in this field. So at the moment, what I do is children who are born with heart defects. You have children, depending, who can be born with a very small hole in the heart, which a lot of times can be diagnosed before they are born as part of the screening prior to birth and when the baby is in the mom's womb itself. A lot of times what we call a postnatal diagnosis, where the child might not be very well. It could be on the first day of life, could be the first week of life. There are certain conditions that will not present until they are few months of age, and sometimes certain years of age. You can have a footballer trying to play in the Premier League and he can collapse on the field and he's found to have a hole in the heart that he did not know about. So it's a very wide range. And in the children's cardiac intensive care, it's a very specialized field, and only certain centers around the world are able to do this. And children sometimes are born with half a heart, what we call a hypoplastic left heart. So we deal with all aspects of looking after these children. Many of them need interventions, whether they are having an operation, an open heart bypass, cardiac bypass surgery, or by cardiac catheterization, which is more like a keyhole surgery, where we can put cardiac catheters through their neck, through the veins, and we can approach the heart, looking at it with CT scans and MRIs and echoes and fluoroscopy, and we can try and avoid cutting them open. These are small children ranging a few hundred grams, so sometimes older children. And also a new part of the specialty is adults. It could be children who have gone on to become adults and then given birth and so on and so forth, who have gone into adulthood, or those ones that are adult intensive care colleagues, cardiac colleagues, may not be comfortable looking after or specialized or have the skill set to look after. They come to us. So my job is managing children who have this condition prior to them having a surgery, stabilizing them, because without what we do, the poor child would die. So we have to stabilize them, make sure we do the right surgery at the right time, and after surgery, they are at their most vulnerable. A lot of times they come back to us with the chest open, and we leave that open until they are ready, because they are bloated, requiring a lot of fluids. They have a lot of support required to their heart. They are on the ventilator, and certain children, their heart stops.
Okay, that's quite intense.
Correct, yeah. And when the heart stops, they have a cardiac arrest. And when that happens, we do CPR and we try to revive them. And certain times they are not responding to CPR. If that were to be the case, in certain conditions, we have criteria. We put them on a heart-lung machine on my unit, on my, it's an emergency. We have to either cut open the chest, or we can do it through the neck. But we put them on something called ECMO, which is ECMO, which basically stands for extracorporeal membrane oxygenation, which is a life-saving. So we keep them on the machine, which does the work of the heart and the lung. And a lot of times, 7 to 10 days on this, and we would expect recovery. And if there's a specific reason why the child crashed in the first place, we need to try and address that. Say, for example, the surgery that we have done, there's been a narrowing, and we need to, on the machine, need to take the child back to the cardiac cath room or for a reoperation, sort those things out. Because we're talking about very small margin. These are millimeter hair width margin. So you and I in adults, our arteries and veins are like highways. Whereas in children, they are 1 or 2 millimeters, and we have to work with a microscope. Our surgical colleagues, intensive care, we are all one big team. And it's team working where we all come together, do the best for the child. It's a very, very specialized field.
This happens through computerized machines, I believe.
That's right. Yeah. So there's a lot of technology involved in pediatric cardiac intensive care. We have a lot of data points that we get. It happens with machines, and these are machines which are like pumps. So these are roller pumps which used to be there 20 years ago. Now we have magnetic levitating pumps which spin the blood, and and then you have a membrane which then removes the bad things like carbon dioxide, puts oxygen back into the membrane, into the blood through the membrane, sends it back to the heart and into the body. And you have to keep that rolling. And whilst we're doing that, you have to thin the blood. Because our blood, see for example, you have a cut. It clots, yeah? So 2 minutes it might, for a few seconds or a minute or two, it might bleed, and then you put pressure or it clots by itself. If you do that, you're taking the blood out of the heart and out of the body. So the machine can clot as well. So we thin the blood. We thin it, but we have to monitor how thin we do. Because if we thin it too much, then the baby can, if it's a small baby, as I said, 500 grams, can bleed into the head. Higher risk of internal bleeding, external bleeding. Then as a secondary problem, we can have liver and renal dysfunction. So looking at a baby as a whole, but primarily concentrating the heart. So the specialty, we have to be good at part of being a good pediatric general intensivist with specialized training in pediatric cardiology and pediatric cardiac critical care. It's a very highly specialized thing. And in the UK, we used to be only 4 children's hospital. We're there amongst the many hospitals. And currently where I'm currently working, so I spent 20 years. I worked in 3 healthcare systems in North America, which was in Toronto Sick Kids, which is sometimes called the Mecca of intensive care. I spent nearly 2 decades in children's ICU, where we looked after all critical care children. About for 2 decades, I've been a consultant in this field for about 16 years now. And currently for the last few years, I'm practicing as Sidra medicine in Qatar, which is a very specialized children's hospital.
Okay, that's great to hear. And for a person like me who is a layman, it's quite interesting that you walked us through the entire process, how it happens, the pre-care, the surgery, the post-care, and how it differs from the adults and how intense it is. Caveating a bit, I would like to understand it from the physician's perspective. Obviously, going through this process, there might be ups, downs, there might be certain failures as well. I'd like to know, how do you manage the stress and the burnout if it occurs in certain scenarios?
I think that's an excellent question, and it's something that a lot of times can be an ignored part of the specialty. Thankfully, it is being addressed more and more globally and in conferences like these. So the stress could be in terms of at a personal level with the amount of intensity with what we do, or in terms of certain times you mentioned that the outcome may not be what we would ideally want, but a lot of times these are predictable. Because you have children who come in with certain criteria, the higher chances of them not being able to leave the unit. And this is something that we counsel the parents right at the start. So if it's a simple sort of certain cardiac surgeries, the outcome, which used to be, say, 50% chance of mortality means death, in the 1970s and 80s have come down to 2 or 3% at the moment currently. But still, it is not 0% mortality. So we're looking to see how things can be made better. And the way we would deal with that is, one, making sure the parents are well updated at all times, and then constantly using the best practice of medicine to make sure we're doing the right thing. And one of the ways of feeling quality and measuring quality for us would be to make sure we're using the best practices that is peer-reviewed around the world, best technology, the best of technology, and we are world leaders in ourselves. So we are here giving invited talks and trying to spread the knowledge that we have made and our publications and presentations that I publish and sharing it to the others. So one is that quality and confidence that we have in dealing with it. But we cannot take away the humanity aspect, the human touch in the midst of big data. And my talk tomorrow, I just finished one talk now, I have a second talk which exactly addresses this question, which is the specialty of pediatric cardiac critical care shifting the paradigm. The paradigm basically means how we've been looking at it and thinking about it until now.
Okay.
What are the factors that are changing and what we should do and can do going ahead, and not to lose the human aspect and the human touch. And one of the things in terms of stress that we do is debriefing.
Okay.
So it's not just me as one clinician, we have a wider team.
Okay.
We have the perfusionists who deal with machines. We have the bedside nurses.
Okay.
We have the respiratory therapists who deal with the ventilators that we put the children on. Obviously, the buck stops with you when you're in charge, but you have a lot of different team members working on different shifts.
Okay.
The way to do it is, one, making sure the team is allowed to ask questions. We debrief the team.
Okay.
And critical incidents will happen. So the main thing is to address smaller incidents and to debrief. And one of my interests as a director of the Sidra Heart Center program is involving not only simulating these incidents. Simulation means doing it in not real patients, doing it with machines, with high fidelity mannequins, and debriefing during those sessions, making people more sort of receptive to this sort of stressful situation.
Okay.
But in real life, when something happens, you address the ethical considerations, you debrief and make sure everybody's on the same page.
Okay.
At a personal level, there are various ways, even outside medicine, we try and use to relieve stress. One, making sure we're doing the right thing, and we have colleagues that we have regular mortality and morbidity meetings.
Okay.
If something is not going the way we want, we would always review them, and if we have done everything well, then despite everything doing well, the outcome, then that's a very known factor that is there. So we sometimes take second opinions from outside the colleagues, maybe in the UK, US. We're a one small community, and almost we know one another very well.
Right.
And personally, I do a lot of sport as well.
Okay.
So I like to
fit
unwind, and I play the piano, which I'm trying to get better at.
Okay.
And I need to do a bit more of meditation to able to help me focus. And we get a lot of time in between our stressful times as well to recuperate and do things outside work, and then come back recharged.
You have quite intensively addressed the question about stress, and it will be helpful to all other professionals as well. You, in the conversation, mentioned something about predicting it in hand. Currently, when it comes to prediction, I would like to address the topic of AI, obviously. So the previous data and all those stuff. Is it in its nascent stage, or is it helping you a lot in currently, or is there a long way to go to actively embed AI into this field?
One of the advantages we have in the field is the availability of data, and it's called big data.
Okay.
So the words big data and machine learning and health analytics,
Okay.
I think because of the amount of data we collect, we have the lines, we have the tubes, we have the monitors, it's easier for us to put together, but it's not always happened. Certain things are still at the nascent state, but certain things, certain centers, we're taking the lead in making things happen. One small example I will give, because whatever data we collect, there's no point in doing that after the event in retrospective.
Okay.
Certainly there's an advantage, and we can review that and see how things can be made better.
Okay.
But taking technology forward, we have electronic numbers coming on to healthcare records directly from the patients.
Okay.
And the patients are on a lot of medication. And one of my interests, and I'm doing this for Sidra as a hospital now, is a guideline that we have come up with to monitor the blood thinning medication that I was talking about.
Okay.
And with the help of our data analysts who are in IT,
Okay.
I've come up with something called proactively in real time as it is happening, to look at the amount of this blood thinning medicine called heparin infusion in this critically ill children on ICU.
Okay.
And the measurement that we have to monitor to make sure we're not giving them too less or too little, whether it's effective, because that becomes the crux in certain conditions when we have to thin the blood in a baby or in an adolescent for various reasons.
Okay.
So as we go along, the machines, the data that we collect, both from the EMR, which is the electronic medical records, from what is being inputted at the bedside, and from the lab, is automated and collected. And if it's not done at the right time, there's a ping that happens which would alert us. So these sort of alerts are very important. It's like you're flying a plane and you have a pilot and a co-pilot. It's important. Otherwise, the plane, you may switch off the wrong engine, which you don't want to happen. If one engine is not working, you don't want the remaining good engine to go. So it's very important that data is collected. And from a quality improvement perspective, we make things happen. There are a lot of other ways you can do data. One is wireless monitoring. In my previous hospital at Birmingham Children's in the UK, rather than having wires attached on the ward when children are outside the ICU, because they may deteriorate and need to come to ICU, or they may be discharged and going to the ward and might become unwell again. How do you monitor them? And that's using a concept same what a weatherman uses on television. You might have seen, there's going to be a tornado in Florida, or there's going to be a weather change and it might rain in Qatar or Abu Dhabi. How do they do it? There's a weather pattern that happens. So using the data, and you're using it to your advantage, and using the criteria. And this project was done by one of my colleagues, Heather Duncan, with McLaren, the Formula One team. Like Ferrari, you have McLaren, which is one of the F1 monitoring. If you look at the F1 circuit, all the engineers are monitoring the driver and the car, and they get all the data. It's happening in real time, and they have to give advice to Jenson Button or another, Michael Schumacher in that film. So that happens in real time. So this sort of thing would predict whether the patient is stable, getting worse, or getting better. So that was another thing. And then the final thing is like weather mapping. It would tell us the direction of travel. So there are these are simpler examples, but very important examples. But there are unit examples, how the whole unit and dashboard, you can use artificial intelligence to look at data and mine. It's called data mining. And I think the future, we think we are biological sort of activity, what we do, but artificial intelligence and big machine learning is something. I'm going to be talking about it. You're very welcome to.
I think from this, there will be a whole new career domain emerging, which involves both computer science and the field of medicine science conglomerating together. What advice would you have for the young professionals who are aspiring to get in? I think which sector to go, which is more promising or something like that, which is more fulfilling, rewarding, in whatever sense it might be.
The future is bright. The future in healthcare is where we are at an inflection point. Just like in real life, we have a lot of technology. 20 years ago, people may not have an email to work with. 25 years ago, I remember 25 years ago or so, roughly, I created my first email. And since then, we have come a long way of what we have today. We have the world at our fingertips. So I think the future is very bright. And in healthcare as well, there's going to be a lot of technology amalgamation in what we do. Personalized medicine, at the moment, every patient is looked at in a similar way. If it comes in with one condition, but the outcome we see is not always the same. You may treat similarly. So genomics is coming in big time. So we may have in the near future, a health passport or something that you come in like a USB plug in, and I get down the data of the person. Correct, the data of what you have, and we can actually predict not only what's happening now, what are the things that you may have issues with in the future that the patient might be at a risk with, and that is something where community and preventative medicine can come into effect, or what are the things we watch out for. I mean, the insurance companies are also, cluing on to this in terms of if the patient has a higher gene to predict diabetes or hypertension or stroke and so on and so forth. So personalized medicine is coming very much into healthcare as a broader thing. And there's another thing called precision medicine. And the precision medicine is trying to cutting edge. No matter what, we have robotic surgeons doing knee replacements these days. We have, in the pediatric cardiac intensive care where we deal with very, very small structures within the heart. All these things a lot of automation is likely to come in. So my advice to youngsters wanting to take this up is this is the right time. You may choose whichever specialty that you have. I'm biased. I love what I do. And you're very welcome if you have any questions from your audience. asking about the specialty.
Sure.
We're standing on the shoulder of giants, a lot before us that have contributed to this. But going ahead, our current generation and the future generation can make a lot of impact. And the current generation, the millennials, the Gen X, they are well alluded to. You're a young person yourself, so you're very well alluded to, technology that is already there.
Yeah.
But for them to come in, to contribute, and to take this at levels that we've never seen before would really be the future. Star Trek, when we were kids, was very much so very much like the futuristic beaming yourself. We've not reached that thing yet, but that's going future with technology happening. A lot of things are due to change. So it's very exciting, and I would highly encourage. It's a very rewarding specialty. You can make a difference in people's lives.